Fast ultrasound examination as a predictor of outcomes after resuscitative thoracotomy. So, thoracotomy, as you know, high risk, low salvage procedure, pretty rare here actually. I don't know if we even do 1 or 2 a year. And I remember my first year of residency there was about 4 or 5, but I'm pretty sure a few years we've gone 0. So low, pretty rare here. Usually in cardiac arrest. One of the theories is there's really little to lose at that point when they've arrested for trauma, and perhaps if you get them back, they can still be an organ donor. It can yield survivors, and there's been multiple studies to show that, so this is why it continues to happen, although there are many skeptics. And some of the survivors are neurologically intact, functioning well, not just with intact brains. They could be quadriplegic or paraplegic, but intact brains and functioning in society. For example, in one of the biggest studies that was done lately by I think it was more of a I think it was multiple studies, 24 studies that were put together, showed a 7.4% survival, and 92% were neurologically attacked. So that's pretty impressive. Not all the studies show that, and there is some variability in survival from 1%, no percent, to 20%. So it really depends on the study. And there are long-term outcomes. They do exist. There's not a lot of long-term outcome data though, so that's pretty uncommon as well. So indications, so this is another thing. There are not great indications for thoracotomy, and that's why it's so heterogeneous from center to center. And then you've got small centers, medium centers, and large centers that do things a little differently. There's no clear clinical indicator, there's no clear biochemical indicator. They've all been really unsuccessful when you study them. There's nothing sufficiently strong enough to exclude or include for thoracotomy, so we're left with pretty much expert consensus or expert opinion. We can look to many places for that, and they all kind of differ a little bit. So you can look to the American College of Surgeons, you can look to EAST, you can look to the Western Trauma Association. And as an example, the American College of Surgeons by Feliciano has a statement out. He was the trauma guru who wrote the major textbook on trauma. His criteria, or their criteria: recent pre-hospital arrest with a precordial wound, cardiac arrest on arrival or during resuscitation, profound hypertension with a truncal wound, and unconscious, and distant or unavailable operating room. So this might be the closest that we use, although maybe many of you don't use the third indication at all, although it's used out there quite a bit. And as an example, the Western Trauma Association publishes this algorithm. They talk more about the time of CPR to do thoracotomy and refractory shock. And it's complicated. We don't have to go through it all, but you can see that we don't really have good indications, and that's why we struggle. And I think many of us wonder whether we should be doing any at all here. So enter the FAST. It's very popular right now for obvious reasons. It's easily done at the bedside, not by a non-radiologist. There's no radiation burden. It's non-invasive. It's fast. It has high sensitivity and specificity for some of the really quick things that we do, such as pericardial effusion, which is important in this particular study. You can repeat it over and over again pretty easily. You don't have to prep the patient. You can perform it perhaps at the same time, sometimes a CPR. I think they were performing the ultrasound concurrently to the thoracotomy at times during this study. It's pretty effective. And if you look at some of the CPR studies and some of the ACLS studies, there's evidence to suggest if you have absence of cardiac activity, then you don't survive. And this is one of the reasons behind this study. So this study is an observational trial looking at whether we can use ultrasound to tell us should we do thoracotomy or not. Can we predict survivors, non-survivors with our FAST up front? Prospective, 3.5 years, major U.S. trauma center, and you can see they do 223 thoracotomies in 3.5 years. That's a lot. 64. So that's huge. Their indications in the study were pretty much at the discretion of the attending surgeon or ED attending. So it just shows you that, and they didn't really specify a distinct criteria, so I'm sure they use heterogeneous criteria. They did, we'll come back to this penetrating trauma, but all penetrating trauma, they did do a thoracotomy on all penetrating trauma. So, I mean, that's in all the criteria, and that's probably the most likely person to survive anyway. Excluded, though, it's interesting, is a lot of this penetrating trauma came into the emerge and then went straight to the operating room. And they might have done a fast en route or in the operating room. They might have done a thoracotomy just as they got to the operating room, or actually did a surgery, but they were all excluded from the study, mostly because it really takes them 2 minutes or less, and you could probably verify that, Kelly, to get from the ED recess room to the operating room. I don't know if it's next door. So I don't know how many centers have a setup like this, but we don't. So it's hard to know whether this will be applicable. Plus, they excluded a lot of the penetrating trauma patients. Their primary outcome, however, was survival to discharge or organ donation. So they used a fast. All ED residents supervised directly by the staff, PGY 2 to 4. Because the ED residents always did the fast, because the general surgery or trauma residents always were doing the thoracotomy. They were done at the same time. The training was a 2-day course, 16 hours with 2 weeks further of hands-on training. And they were able to get peristernal and subxiphoid views. That's all they were going for. Quick and efficient. Is there basically an effusion? What is the heart activity? This is their breakdown basically of the study. 223 thoracotomies, 36 received no fast, so were excluded. We don't know exactly why. None of them survived anyway. It's left a study population of 187, of which 6 survived, with all 6 having a positive fast. There were 3 organ donors with a positive fast. And of note, really what they were looking at is these 111 that were fast negative, so that they didn't have to do a thoracotomy. Pretty young age, 31 years old, 84% male, 51 penetrating, although it's funny that none of the cardiac injuries in the analysis survived, 22.5%, and then 21 patients who had penetrating injuries went straight to the OR and apparently survived really well to discharge. All were fast positive, but were excluded from the analysis. Important point is that the median transport time via EMS is 33 minutes. So that might differ from here. It also differs from some of the other major trauma centers, I think, like San Francisco. They might have very short transport times, which is going to play into whether this thoracotomy will be successful. Really quick results. This was a really nice, simple, designed, quick study, which is why it's so tempting to believe it. Sensitivity, 100%. You know, the numbers are very low, 9, and specificity, 73.7%. And what they're really focusing on is the negative predictive value of 100%. So can we do the fast, see that there's no cardiac activity, see there's no pericardial effusion, and stop? And then we save a lot of resources. Quality of life measures. Really, when you break down the 6 survivors of the study, we have 2 neurologically intact, 1 paraplegic, 1 quadriplegic. They didn't really comment about the brain, although I got the impression that their brain was good for the paraplegic and quadriplegic. And then 2 patients had no good functional outcome and went to long-term facilities. So I don't know, 2 of 6, 4 of 6, depending on what you think of quality of life. So let's just talk. I just put a bunch of discussion points that we could talk about for a few minutes if you want. Just what I picked out of this study that made me think, you know, should we really listen to this study? It's an observational study. Can we really apply this to our center, our life? Although it's really tempting. I really want to apply this because then I would do, well, we don't do very many thoracotomies, then we do less anyway, and I'd feel better about it. So looking at their statistical analysis, they didn't really do any confidence intervals of their sensitivity and specificity, and I think that might be because it would have been too huge with just numbers of 9. But really you should have that, I think, even in an observational prospective study. They excluded a high number of penetrating traumas. I would have liked to have seen the numbers with this penetrating trauma. I don't know why they excluded them. Maybe it was, I don't know if they were able to get the data or why they excluded them, but it would have been nice to see these in the analysis, because these are really the ones we're more interested in, I think, for our center, because we don't usually do blunt thoracotomy on blunt trauma. Drew?
Unless there was a protocol that said you arrive in asystole or vital signs absent right up to the OR, then that's probably the patient population that had a pulse or had cardiac activity. You could survive.
Yeah.
Unless there was a blanket policy to take the non-pulse upstairs. But you would be able to.
Yeah, so there is not a blanket policy to take no pulse upstairs. They all stop in the emergency department. There's nobody who bypasses the ER. I believe in reading the study that those are patients who had ultrasound evidence of pericardial effusion in the setting of penetrating thoracoabdominal trauma who went directly to the OR for sternotomy. Now there was a subset of those in the study, as would be expected, that would arrest en route to the OR or on arrival in the OR, who then went on to get a thoracotomy for management as opposed to a sternotomy, and those patients all survived. Mm-hmm. But the ones who arrested and stayed in the ER long enough to get their resuscitative thoracotomy are the subset that were studied.
It makes perfect sense that they go right to the OR. I mean, it's 2 minutes away. They had a pulse and a minor blood pressure. They had reason to go for sternotomy. They should go right away. Although I would have liked to see it in the study. Drew?
Tell you is chances are no cardiac activity and no significant pericardial effusion. That patient population is probably the one that.
Right.
It's an educational.
It's not going to survive. Yeah. And yeah, separate analysis for blunt and penetrating trauma would have been nice to look at, because a lot of centers don't do the blunt trauma, especially the smaller communities. And although we're medium size, we don't see a lot of penetrating trauma, so we might be small on the trauma size. So a separate analysis would be really helpful. Looking at quality of life measures, there's a lot of discussion about negative utilities, is whether if you survive as a quadriplegic, a paraplegic, or you have all of these people surviving long-term care, is that really a good thing? It's very controversial because if we don't do any thoracotomies, there's a few people that maybe would have survived but won't. But if we go through all of this, are we going to create this huge subset of people that are in homes that don't even know they're in homes? So there's a lot of talk about the negative utilities, and if you look at the negative utilities in this study, it might suggest that we not do thoracotomy at all for 2 survivors, for 223.
You got to know, Dave, why they were paraplegic. Was it because the bullet went through the heart and through the spine, or because they had no flow through their spinal arteries because they cross-clamped the aorta and they ended up as a paraplegic?
Absolutely.
You don't know from just looking
Yeah,
at
we don't have the data, and there's such small numbers, yeah. Something to think about anyway. The indications for thoracotomy weren't tracked, and also the pre-hospital times were, they commented on them, but so we know them, but when we compare to our center or other centers, I'm not sure that we can compare.
I think probably the most interesting thing about this study with respect to its generalizability to other populations are the indications for resuscitative thoracotomy. I'll tell you, at LA County, the indications are if you don't have rigor mortis, if you can get the arm above the head and they're dead, they get a thoracotomy. At least they did before this study. And if you don't do it, you are made to explain in great detail at M&M's, American M&M's, why you decided not to open the chest. So I think your point about looking at blunt and penetrating separately, or perhaps even looking at the subset of patients who would have met classical indications, the indications that we would use in our center, for example, penetrating trauma with less than 15 minutes arrest, or blood trauma with witnessed arrest in the emergency department, might also be helpful.
So this trial was called the transfusion of plasma, platelets, and red blood cells in 1:1 versus 1:2 ratio, and the mortality associated with the severe trauma. So it was recently published this year. The acronym is the PROPPR trial, Pragmatic, Randomized, Optimal Platelet and Plasma Ratios. And essentially it discusses about damage control resuscitation. So damage control resuscitation is rapid hemorrhage control through early administration of blood products in a balanced ratio. What are the goals? To repair intravascular volume deficits, to preserve the O2 carrying capacity, to prevent coagulopathy, and try to repair the endothelium, and prevent dilutional coagulopathy as well. So in this trial, they compared 1:1:1 ratio versus 1:1:2. It is a multi-centered 12-site trial, and how did they do it? Well, with 1:1:1, they essentially got 6 units of each platelets, RBCs, and fresh frozen plasma in a box, so they're kind of units. And in the 1:1:2, basically they alternated it such that there was 2 times as much units of RBCs as there was fresh frozen plasma or platelets. Now, what do we do here, LHSC? So this is our trauma transfusion pathway. It's actually not really either. It's close. So the plasma to RBC ratio after the first 4 units is a 1:1 ratio, but the platelets, assuming the first platelet dose is around 4 to 5 units, is about half. So ours would be similar to maybe describing it as a 1:1 ratio. So in this trial, transfusion was stopped if hemostasis, death, it was determined if it was futile or if there's protocol violations. Eligibility, basically if you had a trauma team activation, you were 15 years of age or older, you had to come directly from the injury scene, so you weren't necessarily transferred patients, which makes the kind of the other inclusion criteria. So initiated transfusion of at least 1 unit of blood within the first hour of arrival or during pre-hospital transport. So it's kind of interesting if you're direct from the scene and you got a unit of blood in pre-hospital transport, that must mean there must be some medics that are carrying blood with them. I don't know. But it's a 12-site trial, so obviously maybe one of the sites had that available. And then you also had to have a prediction that you're going to need a lot of blood. And there was a scoring system, or based on the trauma physician's judgment. So you're included in the trial. There's a bunch of exclusion criteria. So basically most of those around being pregnant, or did you have really severe injuries? Did you have a thoracotomy? Was it predicted that you'd likely die from your injury, like a lethal head injury? So those people were excluded from the trial. What did they look at? They looked at the 24-hour and the 30-day mortality were the primary outcome measures. Okay? The cause of death, which is part of the secondary assessment, was actually determined by a blinded physician that was external to the site. So they were blinded to what treatment group the patient who died was in. Secondary outcome measures, they looked at a bunch of things: time to hemostasis, number of blood products. They looked at one of 23 complications, such as they were looking at ARDS and other kind of complications associated with severe trauma to see if there's a difference between the 2 groups. Looked at ICU, hospital, and ventilator-free days, surgical procedures, etc. And then extended Glasgow outcome score. So in this trial, they planned on 680 people to look at a 10% difference mortality at 24 hours and 12% difference at 30 days. There's a previous prospective cohort study that gave them these numbers and allowed them to assess what sort of sample size they required. There's only 4 patients with missing data, which is pretty amazing considering 680 patients. They basically did some sensitivity analysis with these 4 patients and found it did not affect the outcome. So they also looked at the compliance with the ratios that each treatment group was in. So there was 14,313 trauma team activations, and about 11,185 were actually screened by the study group to see if they met criteria, and 680 did. So of the total trauma team activations, only 6% met criteria to go into this study. So keep that in mind, that it's not really like we're looking at using this on all trauma team activation patients. So only about 6% met the criteria to get in. So the 2 groups were actually quite similar, which is amazing, because usually just statistically, you're going to have 1 in 20 of your, of your characteristics to be different statistically, just based on statistical rules. So injury severity score, pre-randomization hemoglobin, age, blunt percentage, all that stuff was the same between the 2 groups. So there's the 2 groups, 680, they're randomized. There's a few loss to follow-up, as I mentioned, which they allowed for. And to get to the results, in the 24-hour mortality, the difference was 12.7 to 17% in the 2 groups. The confidence interval, however, did straddle 0, so it was not significant. Looking at 30-day mortality, similar trend, improved in the 1-1-1 ratio group versus 1-1-2, but again, the confidence interval straddled 0, so it was not statistically significant. Secondary outcomes, looking at that, basically, death from exsanguination was lower in the 1-1-1 group versus the 1-1-2 group, and they did have they had a higher proportion that attained hemostasis in the OR. The total blood products between the two groups was the same. There was no difference in those 23 complications that I mentioned. Well, I didn't mention them all, but and then this sort of goes through. It's a chart from the trial that shows. Basically, at the top, you can see there's the primary outcome measures and what the p-value was, but as I mentioned, it wasn't statistically significant. Going down, Glasgow outcome score, no statistical significance as well. So just to kind of get to the discussion, so there was a trend towards improved mortality at 24 hours and 30 days in the group receiving 1-1-1 ratio of transfusion products. There was no evidence of harm looking at the complications, and increased, sorry, I'll go back up. The number needed to treat, if you look at the absolute reduction in death, would have been 24 for the 24-hour mark and 27 for the 30-day mark. And as I mentioned, no evidence in trend towards harm. And looking at, would this change our practice? Well, to me, the only thing that would make me be hesitant about changing the practice here, although we don't really have exactly the 1-1-1 or the 1-1-2 ratio, we have a 1-2-1 ratio, is the increased amount of platelets, which essentially the 1-1-1 ratio would be compared to our trauma transfusion pathway. Does that have increased resource utilization on the blood supply chain? So whether that is, do more units have to be used to get the enriched platelets? Does that put more work on the blood bank? I'm not sure. But also looking at statistically, they found that even though there was a trend to improve in the 1-1-1 ratio, they would have needed just about 3,000 patients instead of 680 to prove statistical significance. And they really figured this was because there's a better survival in the 1-1-2 group than they had seen in previous cohort studies. So I don't know if any questions or comments. It's pretty straightforward. And I don't know, yeah, go ahead, John.
Just a question. How many, for a transfusion of platelets, how many donors does that require?
I tried to find that, and I think basically when it says a unit, that's 1 unit of blood. So when you donate 1 unit of blood, that's 1 unit of FFP, that's 1 unit of platelets. But as you know, when we get the platelets, it's about 5 units in the bag. So
No, is it, so are you giving 1 unit of platelets, so 1 donor's platelets, or are you doing what we do, which is 5 donors in 1 bag? So it's really, you need 5 donors in order to do this 1-to-1-to-1.
So I didn't want to give too much details, but they actually, I'll go back up to it, John. They kind of talk about how they did it here. So they give the 6 units of platelets first. So obviously that was all in 1 big bag, or in 1 bag. And then they would alternate FFP and RBC in the 1-1-1 group. So that's how they did it. So I don't think you can get 1 unit of platelets in a bag. I think they gave all the platelets first, and then they alternated the RBCs and the FFP. So that's the order in which they gave it. So probably easiest to just follow it in the 1-1-1. They seem, whenever the package came with platelets within it, they always started with the platelets first, and then they alternated the RBC and FFP. So with us, I think when we get a unit of platelets, the bag, I think there's about 5 units in there, and I think that's 5 donors worth of platelets. Does that sort of answer your question? Kelly, is that correct? And we're a 1-to-1 ratio?
Well, so when they designed our trauma transfusion pathway, the blood bank talked to the people who were working, it was mostly Neil and Daryl at the time, and the way it's written in the documentation is that the dose here contains 6 to 10 units. So I was just saying after you said that I got to go back and look at that because.
Yes. So, and I'm sorry, I have it backwards. It's not 1-to-1, we're 2-1-2. Sorry. Yeah. Okay.
So I'll go back and look at that, and I'll get back to you guys with the answer.
We're lower ratio of platelets relative to what?
And it was designed to be 1-to-1-to-1 based on the idea that platelet dose was 6 to 10. So I'll talk to the blood bank and find out if that's actually what's happening, because based on what you're saying, I'm assuming it's not.
Yeah, I'm not sure. Okay.
World with respect to this paper, the important things. First of all, the investigators wanted the primary outcome to be 24-hour death from exsanguination, and the REB and the funding sources would not allow them to do that. So it was interesting, because that was kind of their most...
In the discussion, they discussed what the FDA was going to prove as being their primary outcome. Exactly. They wanted some earlier assessment, survival, et cetera, but that was what they were allowed, basically.
So just as an introduction, so we know that lung ultrasound is very useful for a number of lung pathologies. We know from the ultrasound world that air equals artifact, and historically we thought that the artifact would prevent us from getting any useful information about the parenchyma of the lung itself, because it would just scatter all of the ultrasound waves. So traditionally, lung ultrasound was only limited to the identification of pneumothorax and pleural effusion. But in 1997, Daniel Lichtenstein, who was an intensivist in France, he was able to demonstrate this B-line signature that was appearing on his patients that had pulmonary interstitial edema and pulmonary fibrosis. And this was a landmark study because it was essentially the first time that an assessment was made of the parenchyma of the lung. And it spawned this huge explosion in interest in lung ultrasound. And now we have very good evidence to support the use of lung ultrasound for a number of etiologies. And we have good evidence about when and how to use them, and some guidelines to help us. So how is lung ultrasound performed? So typically at our center, we perform it using this phased rate cardiac probe. The literature does describe that you can use a curvilinear abdominal probe as well. Now, the only one time that you can use a vascular probe is if you're specifically looking for pneumothorax, but other than that, you do need to use one of these two probes. There's no agreed upon protocol for how to do lung ultrasound. It's not quite as codified as it is for abdominal ultrasound, for example. But one of the common protocols, and the one that we promote here in London as well, is the use of this 8-zone scanning method. So basically 4 zones in each hemithorax. And so you're scanning the anterior chest wall, anterior axillary line, the costophrenic angle, and something at the bottom called the PLAP space. And basically what you're doing is you're looking for these particular signatures. Again, these are artifacts, so they're not representative of particular anatomic features, but they're supposed to give you an indication of what kind of pathology is in that lung. So I wanted to quickly just show you a couple of clips of what do these signatures or artifacts look like. The first one here is normal lung. We're just going to dim the lights so you guys can see it a little bit better. The lights. Those lights.
It's on the podium.
Oh, is it on
Is it the podium?
Yeah, right there.
The monitor.
Yeah.
Oh, it's on the monitor. Okay. Lights. Okay, so this first clip is of a normal aerated lung, and you can see these reverberations that are kind of occurring horizontally all across and at the bottom over there. These are called A lines, and again, this just means that there's normal air in the lung. This over here is an example of B lines. And so these are basically these kind of comets that shoot from the near field all the way to the far field, and you can see in this clip that there's multiple B lines. So when you see this, there's a differential that's associated with them. It includes pulmonary edema, which can be both cardiogenic and non-cardiogenic in nature. It also includes interstitial pneumonia and interstitial pneumonitis, as well as diffuse parenchymal lung diseases. So a couple of things to consider when you see these B lines. This over here is an example of a consolidated lung. So you can see that there's increased echogenicity because of the consolidation. And this one on the right, this is an example of a pleural effusion. So you can see the diaphragm, you can see some fluid, and you can see the lung in here as well. And finally, this is a clip of pneumothorax. And so you need to watch a little bit carefully because it goes a little bit fast. But basically, this part right here is going to have lung slide. And this part over here does not have lung slide. So this zone right here is called the lung point. And this is that exact point where the visceral pleura and the parietal pleura are disconnecting from each other. So if I play it, you can see this little ants on a log right here. And then over here, this is all totally static. So this is indicative of a pneumothorax. This is called a lung point at that very site. Let's turn these lights back on. So it's the pulmonary edema that's of particular interest to us when we're looking for heart failure. And this is technically easier to do than doing a bedside echo. And this is kind of where this study came in. So one of the concerns about lung ultrasound, and specifically B-lines, was that I had mentioned that there was a couple of things on the differential. So the concern was that it may be limited by its low specificity. So they needed to design a trial to actually test this in like one particular clinical setting. So this clinical setting is testing lung ultrasound specifically in acute decompensated heart failure in the emergency department. So this was a paper that was published in Chest in 2015. The objective of this study was to determine the diagnostic accuracy of lung ultrasound when you combine it with clinical assessment and you compare that to just standard workup alone without lung ultrasound in identifying acute decompensated heart failure. The design of this study was a multi-center prospective cohort study, and it was done in 7 Italian emergency departments. Patients were recruited between 2010 and 2012. Inclusion criteria was all adults who were 18 or older who presented to the emergency department with acute dyspnea. And exclusion criteria was dyspnea that was obviously not due to heart failure, so for example in trauma, or for patients who are already invasively ventilated. And it's unfortunate that this last category of invasively ventilated patients was excluded, because oftentimes these are the patients who would have benefited the most from point of care ultrasound. They need something that's readily available that you can do right at the bedside. And if you can just imagine kind of in your mind, you've got this intubated patient, they're super sick, you're wondering if they have heart failure or not, how little utility that portable chest is going to give you in terms of determining whether they're truly in heart failure or not. But in any case, these patients were excluded from this study. So the study protocol was as follows. So a dyspneic patient, when they would arrive to the emergency department, they would be subject to a standard workup which included a history and physical, an ECG, and an AVG. After that was done, the clinician would then diagnose the patient either as having heart failure or non-cardiogenic dyspnea, just based on those features alone. Then that physician would do a lung ultrasound on that patient and then re-diagnose them either with the same thing or see if they had changed their diagnosis. So these were essentially the 2 arms of the study. The one arm was clinical only, and the second arm was clinical plus the combination of lung ultrasound with it. The gold standard that was used in this case was a chart review after the patient was discharged from the hospital. So 2 physicians, a cardiologist and an emergency physician, would go through the entire chart and check to see what was the most likely cause of the patient's dyspnea. And that was set as a gold standard. And then these 2 arms were compared against that gold standard in terms of their sensitivities.
Did they do a chest x-ray in the standard workup?
No, so the chest x-ray was done, but it wasn't part of the standard workup. So it was done afterwards for the sensitivities. So this is the results, and I want to take you down to just this very last row first. This is the chest radiograph. The sensitivity of the chest x-ray for detecting heart failure was about 70%, and the specificity was 82.1%. If you go up to the second last column at lung ultrasound, you can see that the sensitivity is 90%, specificity of 93.5. So just looking at the imaging modalities alone without incorporating anything clinical, you can see that the lung ultrasound in this study was superior than the chest x-ray in detecting heart failure. Now if you go up to this very first row, this is clinical workup. Sensitivity of 85, specificity of 90. So we're actually pretty good clinically, even without the use of a chest x-ray, in determining which patients have heart failure or not. But this final row, this is lung ultrasound implemented. So you take your clinical workup, you put lung ultrasound in with it, and the sensitivities shoot up to 97% and specificity 94. So really, really good in terms of being able to identify that. Yeah?
Chest x-ray, is that just looked at by someone that was blinded to the clinical?
Yeah, so the chest x-ray was just done by the radiologist, and you had to have certain keywords in the chest x-ray in order for it to be considered positive for this. But again, it wasn't part of that protocol, nor did the emergency physician have that chest x-ray. Now I wanted to talk a little bit about likelihood ratios here as well, because these are the ones that are particularly important. And just as a very quick refresher of what the purpose of likelihood ratios is. So this is a measure to see what is the diagnostic utility of a particular test. After you're going to perform a test, what is the probability that the patient is going to have the disease in question? So a good robust test is something that's going to have a positive likelihood ratio of greater than 10 and a negative likelihood ratio of less than 0.1. So if you're looking at these likelihood ratios, you'll notice that lung ultrasound has a positive ratio of 14 and a negative ratio of 0.1. So it's a pretty good test. But when you combine lung ultrasound with clinical workup, the positive ratio shoots up to 37.5 and the negative ratio is 0.03. So really, really good at being able to tell us whether this patient has heart failure or not. So the specific clinical situation where this is super important is kind of when you're on the fence. So again, 85.3% of the time, you can identify which patient is in heart failure. But when you're really not sure, is this patient in heart failure, is this something else, and you need a test that's going to help you get off the fence. If you do a chest x-ray at that point, it's really not going to help you very much. You're neither going to be here nor there. But if you do a lung ultrasound at that point, it has enough of a positive likelihood ratio that you will either go into the camp of, yes, this patient has heart failure, I'm going to go full steam ahead with treatment, or no, I've ruled this out in this patient, I can look at something else. So this is really the value of looking at these likelihood ratios. The strengths of this study, number one, it was a big study. 1,005 patients were enrolled in 7 emergency departments. 46% presented to academic hospitals, 54 in community hospitals. So a pretty wide range in terms of the demographics of the patients. There was also a varied expertise in terms of the lung ultrasound amongst the providers. So everybody at a minimum had to have done at least 40 scans in order to be considered a provider, but the providers varied from residents who had just had the 40 scans to staff physicians who were very skilled in lung ultrasound. And again, this is a strength because you've got the heterogeneity in terms of the providers, but you're coming out with similar results. There was also very strong intra-observer and inter-observer agreement for lung ultrasound interpretation. So for the expert provider, the kappa was 0.97, for the novice it was 0.92, and the inter-observer kappa was 0.94 for agreement for the interpretation. And finally, the authors in the study used a pragmatic definition of heart failure. And so what that means is that they specifically chose not to define any strict criteria for what constituted heart failure, trying to mimic a real world scenario as much as possible, keeping in mind that sometimes they may use guidelines, sometimes they might just rely on their clinical gestalt. So they just chose to leave that to the discretion of the treating physician. Some of the limitations to the study. The first is that the lung ultrasound was not blinded to the clinical picture. So the physician who was doing the lung ultrasound, they had the luxury of seeing the patient in front of them, how they were looking. They had the luxury of seeing what the remaining of their investigations were, and then they were able to perform that lung ultrasound. So that certainly would have caused a bias and inflated the accuracy of the lung ultrasound. This is in contrast to the chest x-ray, which was done by, read by the radiologist who would not have been able to see what the clinical picture of the patient was. The second limitation is that the patients were not enrolled in a consecutive fashion, and whenever you do that, you always run the risk of going into a selection bias. The reason they weren't enrolled consecutively was because in order for the patient to be enrolled, there had to be a physician in the department who was skilled in lung ultrasound, so having had at least those 40 scans, and so that's why that was non-consecutive. Thirdly, the chart review, which was supposed to serve as the effective gold standard, would have definitely been influenced by the emergency diagnosis. So if you're going to diagnose somebody with heart failure in the emergency department, their hospital trajectory is going to reflect heart failure. And then when you're going to look at their chart after their discharge, that's going to reflect heart failure either. So it's not really very separate from what those two arms of the study were. Fourth of all, in this study, the authors assumed that there was this very clear dichotomy between heart failure and non-cardiogenic dyspnea, although we know that oftentimes when a patient is dyspneic, it's multifactorial or there's a bit of a gray zone. At all points, so when the physician had to choose a diagnosis for the study, they had to pick one or the other. And then when the gold standard was done, again, the physician had to pick the one etiology which they thought was more contributory than the other. But we, again, know in practice, you might have, for example, a patient who comes in with a pneumonia, it's worsening, and then all of a sudden they go into heart failure. So unfortunately, the study doesn't answer any questions about those patients who perhaps have a mixed picture. The final limitation is that the study didn't directly compare the clinical picture plus the chest x-ray head-to-head with the clinical picture versus the lung ultrasound. But we saw from the mediocre sensitivity, specificity, and the very mediocre likelihood ratios of the chest x-ray that combining that with the clinical picture, it probably would not have caused that combination to be more suitable than the clinical picture plus lung ultrasound. So the bottom line from the study is that we know from previous studies already that lung ultrasound has superior sensitivity and specificity compared to chest x-ray for a number of pathologies, and this study confirms that it's equally as useful in heart failure. This is a large study. There was good heterogeneity in the patient population in the emergency setting and the user expertise. Interestingly, one of the studies that was done in 2015 in academic emergency medicine compared the difference between a novice ultrasound user and an expert ultrasound user to see if there's a huge difference in terms of their interpretations, and there actually wasn't. So this limitation may in fact not be as big as we thought. Regardless, there's probably still a little bit of overestimation of the lung ultrasound accuracy, but as time goes on, we can expect that there's probably going to be a shift in the choice of imaging when we suspect that there's a patient with heart failure. And as more and more people get trained with lung ultrasound, we'll find that this is becoming a more mainstream form of diagnostic imaging in the emergency department. That's it. Thank you. Any questions?
Just a comment with regard to your ending comment, and that is that it undoubtedly it will become used more, but it's very unlikely that it's going to replace chest X-ray. I think because the chest X-ray is an image that's there for all to see forever, whereas the point-of-care ultrasound that you do and you document on the chart, I may or may not have access to compare a day later. So, and you're also looking for other things. You know, does this person have, you know, mediastinum? Do they have masses? What have you? So, you're still going to be the chest X-rays.
Yeah, and you're touching on an area of evolution as well, where critical care is already now in the final throes of being able to transfer acute path images directly to the PACS system with a report. I should say CERN, not PACS. So they are readily available now as long as you hit the clip button, and I keep telling everyone hit clip, hit clip, hit clip, because those are accessible. But that, I think, culture will change because it's becoming more and more recognized that decision making is happening based on point-of-care ultrasound. And because of this serial ability to repeat the test, and especially with B-lines, there's very good evidence that as people improve, the B-lines decrease. You can start someone on BiPAP and you can count them going down as they clinically improve based on their capillary wedge pressures. So it's a point well taken. I don't think chest X-rays are going away anytime soon, but certainly the initial chest X-ray, which we know takes 10 or 15 minutes, is no longer going to be your initial test of choice. And as a follow-up just to what Muhammad's talking about, the point-of-care ultrasound team that we have here is just in the final throes of finishing off details to be able to offer to faculty short courses in lung ultrasound and follow-up quality assurance to get whoever wants more ultrasound experience in lung ultrasound up to speed. So hopefully that announcement will come in the next couple of weeks.
When you say you can follow it, are you counting a number of things per screen? Or what?
Yeah, so basically it's the number of B-lines per screen. It's fraught with a bit of error in that a lot of the studies use 12 zones on each side, so it's a 24-zone assessment, which no one's ever going to do. And that's where most of those studies come from. But the overall confluence of B-lines or singularity of B-lines in zones will change. Next time you have someone on BiPAP, once you get a little more familiar, you may already take a look at their B-lines right before you put them on, or take a look half an hour into it. And it's a dramatic change. Very dynamic, in front of your face kind of.
In severe heart failure, they usually have coalescent B-lines. So they kind of just basically look at one large screen of just B-lines. So it's kind of hard to count when that's the case, but when it becomes the range of interstitial edema, you can actually kind of count individual B-lines and the progression of this.